Welcome to the Department of Medicine Grand Rounds. The CME code for today is 25163. And to introduce our speaker for today is the Division Chief for Infectious Diseases, Keith Kay. Keith?
Thanks, David. Welcome, everybody. It's my distinct pleasure to introduce our speaker for today's Medicine Grand Rounds, and that's Dr. Tanaya Bhowmick, who is an associate professor of medicine. Tanaya completed medical school at Drexel University College of Medicine, and then she's really been a Rutgers product from then on. She came to RWJMS for residency in internal medicine and followed up with a fellowship in infectious diseases here, and has really been a critical member, a pillar, so to speak, of our division for several years now. She joined the faculty and really was the forerunner for our antimicrobial stewardship program, which has reached a gold status in terms of state ratings, which she helped create really excellence here. She also serves as program director for ID Fellowship, where we consistently fill our match with excellent fellows. She also is quite active not only locally in stewardship, but also regionally and nationally. She also excels on the academic side of things. She's been involved in clinical trials as well as investigator-initiated sponsored trials as well. Her particular interests outside of stewardship also include antibiotic resistance, novel therapeutics, and the microbiome, and I'm really looking forward to her talk today on diagnostic stewardship. Tanaya?
Thank you very much for that warm introduction. I'm going to start sharing my screen. So most people have heard about antimicrobial stewardship. And we have the Joint Commission to thank for this. And I'd say that diagnostic stewardship works hand in hand with antimicrobial stewardship. The term diagnostic stewardship was coined by Dr. Daniel Morgan in a viewpoint to JAMA in 2017. And really involves modifying the process of ordering, performing, and reporting diagnostic tests to improve the treatment of infections and other conditions. In the field of infectious diseases, the gold standard for diagnosis is often positive culture. Unfortunately, a positive culture does not equal a disease state. There are other factors that need to be considered because this could be a false positive indicating contamination, colonization, and this is where diagnostic stewardship comes into play. We need to make sure that the appropriate tests are ordered or not ordered and interpreted to optimize diagnostic precision to ensure appropriate antimicrobial treatment. This schematic demonstrates the different steps of testing and the areas in which diagnostic stewardship can play a role. So you have your physician here at the top who's directly interacting with the patient and has to determine if and which tests to order. Then when placing the order, there are a few different methods within the EMR that can help guide decision support. Then it's handed off to the people that are collecting the sample, transporting specimens to the lab, then off to the lab where they do the processing of the specimen and do additional testing as they see fit. And then there's the reporting out of the information, which could serve as another important point of guidance. And then we go back and feed the results to the physician who had ordered the test in the first place, who now has to interpret the results and determine how it may affect their treatment of the patient. Diagnostic stewardship is the right test for the right patient, prompting the right action. And antimicrobial stewardship has always been touted kind of as the right drug at the right time, at the right dose, for the right duration. If you look at this graphic, the diagnostic stewardship part starts a little bit before antimicrobial stewardship because tests are usually ordered prior to the initiation of empiric antibiotics. With antimicrobial stewardship, we can make adjustments and recommendations on antibiotics, but it's often an uphill battle when a positive culture is staring people in the face. You see that positive result, people feel compelled that they need to act on it. So we can correct for the over-testing and misdiagnosis of colonization and contamination as infection. Diagnostic stewardship can really reduce unnecessary antibiotic use. Ordering of the tests is probably the most important step of this whole schematic. There's a lot of psychology at play here, specifically the fear of missing a diagnosis. There's also statistics to consider. It's important to understand that no test is 100% sensitive and specific. So if you have a low pretest probability and a test turns out to be positive, we have to know how we're going to interpret that results. So if we can try to intervene earlier on in this schematic of the ordering of the tests, we can make a huge difference. So there is a survey that was administered to internal medicine residents regarding what they considered a full fever workup to be when they were cross-covering patients, and there were febrile episodes. And the majority of them ordered the same tests, and they repeated these tests irrespective of the patient's symptoms or changes in clinical scenarios. So everyone got blood cultures, an X-ray, a UA, and this is a culture of pan-culturing. And this is a problem because for multiple levels. So first, there is the reporting purpose aspect of it. So we have our National Health and Safety Network, which evaluates all hospital HAIs, hospital-associated infections, and affects reimbursement. But there are downstream effects on the individual patients themselves who are receiving potentially unnecessary treatment. There was a study that evaluated all CAUTIs, which are the catheter-associated urinary tract infections, by a retrospective chart review. It saw that more than half the time there was an alternative reason for fever or instability when a urine culture was ordered, and that the CAUTIs that were met by criteria were really met because of this pan-culturing process. Along the lines of psychology, this was a propensity score stratified cohort study that looked at intubated patients who had fever or leukocytosis, leukopenia, some abnormality in a white cell without radiographic findings, vent changes, purulent secretions. And they compared the patients who had respiratory cultures versus those who didn't. And what they found is that the patients who had respiratory cultures ended up receiving antibiotics for a longer duration than those who did not have it. So orange is the respiratory cultures not performed, blue is when they were performed. They were 2.57 times more likely to be prescribed antibiotics. I have a almost 5-year-old and a 2.5, almost 3-year-old, and they attend a Montessori school. Every Wednesday they have a session on mindfulness. And mindfulness is not just some gimmick. I think there are a lot of health benefits to mindfulness. And it's been touted to be helpful in enhancing focus, better concentration, increased team engagement, emotional control, less stress. And what I'd like to focus on is the aspect of improved decision-making. And in this correspondence, the authors discussed creating an algorithm that combined mindfulness in the evaluation of fever and the usefulness of pan cultures. And we're treating this like an antibiotic timeout, really encouraging like a diagnostic timeout or a culture timeout. So it's a deliberate fever workup. If you look at the algorithm, start off with a fever. And the next question is, do you know why they're having a fever? Well, yeah, if you know what it is and there hasn't been any change in symptoms or clinical status, then go ahead and manage those symptoms. If it hasn't been previously evaluated, and they're able to provide a history, go ahead and get that targeted evaluation based on the symptoms that the patient's able to tell you about. If they're not able to give you a history, which happens, go ahead and do a broad evaluation, but focus on objective findings. So really kind of thinking this through as opposed to being an automatic type of knee-jerk reaction. This is a scenario I was hoping to find a screenshot, but I didn't get around to it, that we see often where there's a patient who's in septic shock who has elevated LFTs, and the recommendations are written out that you should check an EBV, a CMV, a VZV, an HSV, a hepatitis panel, an ANA, a ceruloplasm. Do we really need to order this huge, extensive workup? So there was a study that simulated the evaluation of 10,000 adults. This was outpatient, so it's a little different than the scenario that I posed to you. And they found that extensive testing, which was testing for all potential diseases at once, was slightly more cost effective in terms of monetary costs and required fewer doctor visits. So I think this is very different than our inpatient scenario, because we don't have these multiple doctor visits in the hospital. But it generated a lot more false positives compared to that focused testing. So it's really important to consider the pretest probabilities and patient histories when deciding what tests to do. And now more than ever, we're flooded with extensive test menus. I just typed in hepatitis into Epic, and you have this huge library of tests. So it's important, if you're suggesting a test or you really want to know a diagnosis, know what test it is that you need to order, and be specific if you're the one recommending it in your recommendations, so that the correct test does happen, so you get to the right diagnosis, whether you're looking for an antibody or a PCR, along those lines. So to try and encourage appropriate test ordering, this was an education-based approach, the Kicking County campaign. And the first part is really making sure that the test is ordered only if it's indicated. And this, again, involves a cerebral, deliberate thought process. We don't want that knee-jerk reaction. So a study was conducted at the VA, and they looked at pre and post intervention of contemporaneous groups. And intervention really consisted of education using this diagnostic algorithm with case-based audit and feedback. And it's a very long algorithm, but I just screenshotted the top of it here for you. And what you'll see is they start with, does the patient have any CAUTI symptoms? And they give you a whole list of a lot of non-specific symptoms, including fever. But also dysuria frequency. And if they don't have any symptoms that fall within that bucket, then don't send the urine culture. If they do have some of these symptoms, is there a non-UTI diagnosis that likely accounts for the symptoms? And if the answer is yes, then go ahead and work up the other causes. Let's not focus on the urine anymore, because once that urine culture is done and you have a positive result, we know that everyone's going to think this is a UTI. This was a multifaceted study. It required a lot of people, a lot of manpower up front. And what they found when they looked at the baseline compared to the intervention year, they saw a significant decrease in the number of urine cultures that were sent. And this was maintained in the maintenance year. In the maintenance year, they're only going back quarterly to review the cases with the house lab. And what's really nice to see is that this also affected, not surprisingly, the rate of asymptomatic bacteriuria that was treated. So the baseline time period is 1.6, and it went down into the intervention period and also in the maintenance period. Another education-based approach, kind of using an algorithm, was evaluating blood cultures. And this was done at Hopkins, where they developed this algorithm of blood culture diagnostic utility in common scenarios. And they excluded neutropenic patients. They had ID, stewardship, microlab, critical care, hospital medicine, surgery input. And they had pocket cards that were distributed to the staff and in-person education with feedback on the algorithm compliance and to the staff every 2 months. And this is the algorithm. It is quite busy, but I think it nicely breaks down the different scenarios and makes some things very clear that this definitely, you should be getting blood cultures, this, you shouldn't be getting blood cultures, and this is where the gray is. So if we start here for blood cultures that being considered for a new clinical event, if there's severe sepsis, septic shock, infective endocarditis, endovascular infection, go ahead and get those blood cultures and you're done. If it's not any of those scenarios, then you look at the pretest probability of bacteremia. And in the cases where there's an epidural abscess or concern for discitis or native osteo, again, go ahead and get those blood cultures. But if it's on the opposite end of the spectrum, where it's an isolated fever, very low pretest probability, post-op fever within 48 hours of surgery, non-severe cellulitis, blood cultures aren't recommended in those situations. It's this intermediate area, which is a little bit gray, with conditions of acute pyelocholangitis. And there's a series of questions that follow up there, and again, guiding you in one direction or the other. The other section is for blood cultures that are being considered to document clearance of bacteremia. Then it goes by what organism are you looking to clear, what are your other risk factors, and again, recommendations to get blood cultures versus not getting blood cultures. And so what they found was a decrease in the number of blood cultures that were being sent on patients, and they used a surgical ICU as a control, and it was a 30% reduction. Now, the investigators did a very thorough job reviewing for any harm that could be caused by not checking the blood cultures, and they did note an increase in mortality among the ward patients in both in the post-intervention group, both with and without blood cultures. And when they looked deeper into the reason behind this, they found that most of the patients were either admitted for hospice, about a quarter for cardiopulmonary cause of death. And as you may or may not recall, last summer we had a blood culture shortage nationwide, which we were affected by. And this was the best practice alert that was implemented through EPIC, where, you know, it's stating that we have blood culture shortage. Do you really want to order this? And then if you really did want to order this, you have to attest to the reasons why you're ordering it and give an indication. It's really forcing the hand to make sure that testing is done appropriately. And so the algorithm that I just showed you is something that we're actually piloting in our medical ICU right now. We started giving out the algorithm, and between John Mills and myself, I've been going and meeting with the medical ICU teams about every 2 weeks. We distribute the algorithm electronically, and just last week I got to hand out the laminated cards. And already you can see that the red being our shock trauma unit, which kind of stayed level compared to medical ICU, which is uptrending, seems to be downtrending. And I'm not sure if we can say definitively this is because of our education, but it's nice to see at least that it's trending down. Based on feedback from our medicine house staff, who I've discussed this with, we're hoping to roll this out to the medical units next, because it seems like there are a lot of blood cultures that are being done on the floors, which may or may not be necessary. So we'll be targeting MTS and hospitalists. And also, for y'all to be aware, we're working on an app that's going to house guidelines. And the initial purpose of the app that we had been thinking about was more for antimicrobial stewardship, but diagnostic stewardship really is something that plays a role with it, and planning to have some of these diagnostic stewardship algorithms built into this app and built out. Another driving force behind testing and prescribing are requests from patients. So there have been various organizations that have implemented these commitment posters, putting them up in exam rooms. So physicians are pledging their commitment to judicious antibiotic prescribing. And these are intended to affect the clinician's behavior rather than the patient's behavior. But I think if patients see this, they might not be as likely to maybe push for antibiotics in scenarios where they're not needed. And there was a randomized controlled trial that the public commitment posters were effective and significantly reduced inappropriate antibiotic prescribing amongst primary care providers in the outpatient setting. So along the same vein, the ABIM Foundation began the Choosing Wisely campaign in 2012. And the purpose was really to spark conversation between clinicians, patients about what tests, treatments, and procedures are needed and which ones aren't. Initially, there were like 9 national societies that offered 45 examples of tests or treatments that were commonly used in their field, but lacked strong supporting evidence. And I couldn't find recent data, but I saw something about 80 specialty societies have been partnered up by like 2016. There were over 1,000 publications. Again, kind of emphasizing the importance of, do we really need certain tests and procedures in the medical field? I mean, we're lucky we're in the US, we have the ability to have access to all these things, but the question is, are they doing any benefit? Or are we actually creating some harm with this? With requiring additional testing, with it costing money, lots of different aspects that aren't beneficial if we overtest. So part of the ordering of the test is also kind of test availability. Procalcitonin, I think, is still somewhat controversial for clinicians. This is a test that was approved by the FDA in 2017, really in an effort to kind of distinguish between those infections or medical conditions that were caused by bacteria versus either viral or not bacteria. There were initial studies that suggested a reduction in mortality and antibiotic exposure. Fortunately, those studies weren't optimal. There was a lot of crossover. I'm not going to go into a lot of detail, but there was a study that was published recently in December of last year, and it was a multi-center randomized trial, and they did daily Procal guided protocol and they showed a reduction in antibiotic use, but the reduction was by a day and it required really intense monitoring, and it just doesn't seem to have the best bang for its buck. We implemented the Procal test in our hospital a little while back, and we decided to do a look back at our own data, and this data is, I think, from 2022, a 2-week look back that the Poly, our ICU pharmacist, and Rutgers pharmacy faculty did. And despite there being 135 orders over 2 weeks, the range of provider reaction to the reported Procal was only like 10% at best. So it's being ordered, it's being performed, but no one's actually paying attention to the results because it's there now. So about a year ago, the health system looked to evaluate this test because they thought, is this really a useful test? And they found they're spending more than $2 million a year on Procal. And so there's a lab stewardship committee at the system level, and they were looking at actually removing it altogether for adults, leaving it just for pediatrics, and just leaving it in like the order sets for adults. And so what they tried to do is we'll just leave it in the order sets. We won't remove the test altogether. And what they found was there's no change. And then they found that it was because the orders were now in people's personalized order sets. So I recently saw an SBAR about removal of Procal altogether from the menu. But I checked last night and it's still orderable. So this just goes to show that if a test is out there and made available, then people can pick up on it. And it's important to choose wisely in terms of if you're deciding to let a test be run at your institution or bring those instruments on board. And along with test availability, it's also just kind of working with order sets and working with the system. So a very simple change can make a huge difference. So this was a before and after study of emergency department patients. And the intervention was very, very simple. They removed the orders for a UA with reflex to urine culture from the highly accessible list of frequently ordered tests. And they just retained a UA with reflex to microscopy. Now you could still order a urine culture. It just required 3 extra mouse clicks. So it made it very deliberate. Someone really wants a urine culture, they'll get it, but you have to think about it, and actually they made it a little bit harder. And what they found was a significant decrease in the rates of urine culture ordering. Now, we had kind of the opposite effect here. Our stewardship group met with the emergency department physicians about culturing practices about a year ago. And we wanted to focus on urine cultures, actually, because we felt like a lot of urine cultures were getting sent in the ED and they were positive, and then people were getting treated. And we didn't always think, when we did our anecdotal look back, why is this happening? So it was quite unsettling what we discovered. What we found out from them was that there were new order sets that were implemented in November of 2023, where they were the automatic UA reflex urine culture was the only available urine test in several of the ED order sets. And so when we had this conversation, we figured this out. The ED physicians brought it up to their leadership. We brought it up through ID Collaborative. And it went to the Lab Stewardship Committee, the Diagnostic Stewardship Committee of the system, and they're the ones who compiled the data and found this beautiful, and made this beautiful graph that shows a very sharp incline of the ED UA reflex culture orders, basically after the implementation of this test. And the downstream effects are we also now see a lot more positive cultures as a result of that. And it's become an uphill battle now to just change the order set. So this again goes to show the test availability or order sets working with the system it's super important to try to get things right or guide people in the correct path to avoid unnecessary testing. And with everyone on Epic or other electronic health records, having an alert that can guide you to make an order based on information accessible in EMR has been very helpful. So this was a best practice alert that was implemented if there was a patient and someone was trying to order C. diff on them, and it activated if they were given laxatives or had a negative test within the past 48 hours for C. diff, or if they had a positive test in the last 14 days. And an alert would pop up indicating the reason for the alert with a hyperlink to the best testing practices. And then there was a soft stop where the providers were instructed to call the micro lab for approval if the testing was still deemed necessary. And I think they kind of tricked people because at the bottom of this BPA, there was a sign button. So I think people often thought, okay, I'll call them, I'll just hit the sign button and the test will go through. But it actually then took you to a hard stop where the testing could not proceed without approval from the microbiology lab. So now you had to make this phone call. And the micro lab approved all order requests. People called, they got a passcode, and they could put in the order. And what they found was a decrease in the number of weekly orders. So kind of, I don't want to say putting barriers, but putting in some hard stops and really trying to make it deliberate that people really want the test. And they didn't find any adverse outcomes by implementing this either. So similar to the prior study, however, in the prior study, everyone got approved. Here is a little bit different. And this is kind of like a prior authorization that we do with antibiotics. So if patients met certain criteria, physicians had to actually plead their case to the antimicrobial stewardship pharmacist, who is our Arshina, and get approval in order to get the test. So we're not doing this here. This was done at this other institution. And they get the BPA, they say you have to discuss this with the antimicrobial stewardship pharmacist team, and then you'd have to enter the approving team member's name. And what they found was a decrease in the rates of testing after implementing this BPA. Test processing, I'm not going to spend too much time on this. This is a lot that happens on the back end in the lab. Some of it involves evaluating quality of specimens. So sometimes you'll see sputum cultures that are rejected for oral contamination because the techs will look at sputum gram stains, and they see that there's basically saliva in there, you're going to grow lots of different organisms. You're not really getting stuff that's deeper down in the lungs to give you the answer that you want. They'll reject foreign stool for C. diff. But another item that's done on the back end from the lab is rapid diagnostics. And I'm going to go into detail about what we have here in a bit. But this requires no additional input from the physicians that are caring for the patients, and the lab sees an opportunity to process some specimens and get results faster. And this was a study that we had done here at our institution, just showing that the time to full identification, the blue bar, and this was our traditional methods, went down dramatically once we implemented PCR technology. So it took 1 to 2 days for identification previously, and it went down to 1 to 2 hours. And this is important because it's shown decreased duration of broad spectrum antibiotics. And moreover, these studies have shown, as another study, this was looking at before and after bacteremic in patients, implementing another rapid diagnostic assay into an active stewardship program. And the gray is the time that the results are uploaded into the EMR, and you can see from the graph that it's significantly faster. And in addition to time to optimal therapy, they're able to show a decrease in hospital length of stay. Reporting is another step in the process that's very helpful with guiding potential treatment or not treatment of test results. So the microbiology laboratories have been practicing elements of diagnostic stewardship for years. The Clinical Laboratory Standards Institute has a document directed to lab directors regarding susceptibility reporting. And this is an example table. There are different tiers at the top. And we zoom in. Tier 1 is for antibiotics, antimicrobials that are appropriate for routine, primary testing, and reporting. If we go to tier 2, it's again routine testing, but the reporting can follow a cascade fashion, and I'll show you an example of that in a little bit. Tier 3 is tests that are appropriate for routine primary testing, but includes additional antimicrobials for areas that serve high risk patients who are at risk for multi-drug resistant organisms. And then tier 4 is antibiotic agents that might require testing if it's requested by the clinician, or if the other tier antimicrobials are not optimal because of other factors. And so when organisms, bacteria are worked up in the lab, they're worked up and it's a whole panel of different antibiotics that they're tested against, but only some of them get reported. And so here you have a very old sputum culture from over 10 years ago of a Klebsiella. And below there's a urine culture, and it's also growing Klebsiella, but you'll notice that the list of antibiotics is much longer for the urine versus the sputum. And the reason for this being is this cascade reporting mechanism. So here our gentamicin is susceptible, and so other higher generations of aminoglycosides aren't reported, whereas here the gent is resistant, and therefore tobramycin and amikacin and tobramycin was resistant, so amikacin was reported. Along the same line, cefazolin was susceptible here, so that's the only cephalosporin that's reported, versus in the bottom, cefazolin's resistant, so they go on to report ceftriaxone, which also is resistant, so they go on to report meropenem. And then because this is such a resistant organism, additional testing is done in the back end of the lab to look at some of the more broad spectrum agents. And now we have luckily we have newer antibiotics that we can test for and use for our patients. And then nitrofurantoin is only reported in the urine because that's the only place where it's effective. So sometimes it's helpful to report what's not there, because again, this is playing into the psychology of antibiotic ordering and choices. So this was a quasi-experimental study that looked at adults with respiratory cultures that were growing commensal flora, and then also evaluated if they're receiving anti-MRSA and anti-pseudomonal antimicrobial therapy. And the intervention was very simple. In the culture results comments, rather than just writing alone that there's commensal respiratory flora only, they specifically wrote out, there is no Staph aureus, there's no MRSA, there's no Pseudomonas here. And what they wanted to look at was the de-escalation or discontinuation changed to a narrower spectrum agent after the final culture result. And by adding this simple little phrase of saying what's not there, they were able to show a significant decrease in the de-escalation discontinuation. It went from 39% after final culture results to 73%. And so there was a 5.5-fold increased odds of de-escalation. And along with that, there was a reduction in acute kidney injury as well. So this is helpful and important. Sometimes you can give no report at all. This was a before and after modified reporting of urine cultures. And so all cultures from non-catheterized inpatients from study wards were processed as usual in the microbiology laboratory. However, positive results from these from non-catheterized specimens were no longer reported automatically. Instead, this message was posted in the EMR. The majority of positive urine cultures from inpatients without an indwelling urinary catheter represent asymptomatic bacteriuria. If you strongly suspect that your patient has developed a UTI, please call us. And the primary outcome was the rate of asymptomatic bacteriuria in non-catheterized outpatients. And if someone called, the results were immediate released to the clinician who called. So again, adding that kind of step. Before we looked at the steps of ordering tests, this is an additional step of getting the result from the test. And what they found was a absolute risk reduction of 36% in the rate of treatment of asymptomatic bacteriuria. Sometimes when a lab has altered their processing of a procedure, they want to make sure that these results are conveyed to the treating clinicians. So kind of similar to prospective audit and feedback, infection prevention does this for a contact isolation where they see a positive result and then they go ahead and either put the patient on isolation if it's a multi-drug resistant organism, or contact the teams or the nurses. Antimicrobial stewardship does this for certain antibiotics. And so this is kind of active guidance. So this was a prospective randomized controlled trial. We had 3 arms. They looked at standard blood culture processing, then they added this rapid multiplex PCR with templated comments, so it comes already there. And then the third arm was the rapid tests with the templated comments and real-time antimicrobial stewardship. And so you had active guidance by a human. And the primary outcome was the antimicrobial duration of therapy. And what they found was, here we have organism identification. And despite having results faster here, the de-escalation took a while to occur still. Escalation happened pretty rapidly, but the de-escalation took a while. When they added stewardship, you can see this is our timeline. It happened even faster. And there is no difference in mortality, length of stay. We also published on a study that was before and after cohort retrospective observational study where when we implemented an instrument for gram-negative bacteremia. And we looked at those patients who had had antibiotics for at least 72 hours. And the instrument gave us results within 8 hours. We had our stewardship team review and perform interventions as needed. And we found there was a significant decrease in the duration of empiric antibiotics and modification within 24 hours of susceptibility results, which was improved once we had real-time feedback. So I wanted to share, since this is grand rounds for our group, a history of our rapid diagnostics. So back in July of 2014, we initially were just running the instrument in the background for gram positives. And when we evaluated that data, we didn't see a significant enough decrease in the time to direct therapy. We were it was one of the chart graphs I showed you earlier. We got results rather than 1 to 2 days, it took 1 to 2 hours, but it was still taking about a day for people to make changes to the antimicrobial regimen. So then we started making phone calls. We have the lab contact our stewardship team. We would review the patient's chart. We'd contact the primary teams and make recommendations. We implemented the T2 Candida system and decided to use the same method of reporting. So our stewardship team was reviewing those results, positive and negative, and making recommendations accordingly. And then in May of 2019, we implemented another instrument for gram negatives. And we didn't want to overstretch the group. Initially, it was attendings and our pharmacist. And then at this point, we still hadn't switched over to ID fellows. We don't want to overstretch our group. We didn't overstretch the micro lab because they were the ones who are also inputting extra data. So we stopped calling and reviewing the gram positives, and we only focused on the gram negatives and our T2 Candida. And we actually looked back later and we found that the time to directed therapy for gram positives started increasing again. So we realized that our efforts still needed to be there for our gram positive instruments. So in December of 2022, we added back our gram positives, and now you likely will get our epic chats from our ID fellows who do the vast majority of the reviewing, if not our stewardship pharmacists or Sheena. So having a human at the bedside or in direct conversation at the time of results that results received and are being interpreted really has the best results. And just imagine if there was a person present at the time that the decision is being made to order or not order a test. But this requires resources. And if we can't have a person there, we need to get administrative buy-in to provide IT resources to build the clinical decision support and champion it. And it's so hard to reach everyone in an institution. Yes, we have these online educational platforms, but to really make it a priority in the minds of those who are completing the modules and have it like stick into their minds and actually implement it, it's not easy. It really is a change in the culture. We are in talks about having an app that people can download on their phones, which will help with decision support at the point of care. And we're planning to build out algorithms for antibiotics as well as diagnostic stewardship. So we'll have our guidelines, which we have posted on the bridge and we have in our Google Drive for community-acquired pneumonia, skin and soft tissue infections, but we'll also have like our blood culture algorithm. And it'll be built out so then rather it being a complicated flow chart, there'll just be a series of questions that lead to the final decision about which antibiotic to use or whether or not to order blood cultures. There are a lot of emerging technologies. I mentioned rapid diagnostics now a few times that give information so much faster. And then if we can leverage the electronic medical record where we can build in relevant patient-specific data into best practice alerts and kind of guide in decision-making, that's something else that's kind of up and coming. There are even AI bots that are trained on case presentations and being looked at for predictive diagnostics. So the future is quite bright here. There's an important role of diagnostic stewardship for caring of our patients. It nicely complements antimicrobial stewardship. And as for both, to make the biggest impact, we need to understand the psychology of the clinicians ordering the tests. Antibiotics, Dr. Borkoff says, is drugs of fear. And ordering tests, it's kind of similar along the same lines because it's that fear of missing a diagnosis. I should order this just in case. But there are downstream consequences of antibiotics. It's potential C. diff, potential drug resistance. With these tests, it's potential false positives. And then knowing how to interpret those results. This is really a collaborative effort of a multidisciplinary team that consists of microbiologists, infection preventionists, antimicrobial stewards, and really the input and buy-in from all the clinicians that are taking care of these patients. Further reaching efforts can be attained by leveraging technology and using it for educational purposes. By ensuring that the right diagnosis is reached, we can then prescribe the right treatment and improve patient care. And as the saying goes, ordering a diagnostic test is much like picking your nose in public. You better know what you're going to do if you get a positive result. Thank you for your attention.
Thank you, Tanaya. That was fantastic and quite a closer too. So there's Dr. Buettner, you had a question. I don't know if you wanted to unmute yourself and ask the question, or if Tanaya, if you can see it and you just want to read it and answer it yourself.
Yeah, I mean, the question is whether procalcitonin is not helpful in differentiating between trauma and infection-induced fever. Don't you agree with that? Or
There are lots of limitations. I mean, there have been hour-long debates at some of our ID meetings even to discuss the value of procalcitonin. And it's not that it's necessarily a bad test, but it's when it's implemented at the system level, making sure that it's used appropriately and people look at the result. Because what we're finding is people just order it and it's part of the order set. And there's also, I think it was for Procal, automatically it gets ordered again 2 days later, or 1 day later, and people don't pay attention to it. So I think in certain scenarios, it can be of value, but the way that it's being used currently, it's not valuable.
I get that. Yeah, thanks.
Thank you. There's a question from Dr. Jagpal.
Oh, not a question, but I had gone to this conference one time where they were saying that they were actually going to take ordering out of our hands entirely, and we were going to be asked to submit like an assessment statement, problem representation statement to the lab, and someone at the lab would decide what would make sense in that scenario. Is there any thought that that could be the future of medicine? The rationale was that in the past with internal medicine, we had like 1 page of possible tests that could be ordered, and now it's entire textbooks of possible tests. So it's unreasonable perhaps to expect an internist to truly know the sensitivity, specificity of all of the different options.
I mean, in some ways it sounds very future state. Problem is that like, who's going to be the one that does that? I mean, I guess they could build out algorithms. But I mean, with AI, you never know. But
Yeah.
I agree, like what they said there's so many tests. And even knowing like little things within Epic, like our TB, our AFB cultures, if you order the wrong one, it gets sent to LabCorp and doesn't get processed here. Like there are nuances even within the test ordering. So it's helpful to have that knowledge in the background, but it's hard to expect everyone to know that because we have all of our internists that are potentially taking care of patients who are concerned about TB and not ID. Not everyone has ID involved right up front when you're ordering the tests.
Thank you, Dr. Clark. You had a question?
Great. Thanks for a wonderful talk. I think really thinking through all of these steps, you know, it's not something I spend my time doing, and obviously you do, and it's important that people do. You mentioned, I think a couple of times, sort of a separate app or that, you know, to help guide this, or sort of point of care things. There are also, and I know this is fraught with multiple committees also, but would it be easier to have things that are really linked into Epic? You know, sort of putting in, sounds like one of the institutions you mentioned had a, you know, link that popped up, but there are I've seen other places where there are resources directly linked, or I don't know if you've thought about that or how you see the pros and cons given sort of reality, but also really what might be ideal state.
So we've looked into that several times because I think that would be very helpful to have it there instead of having things living on the bridge that people can't access. And there's just been, like you kind of alluded to, just it's difficult. We have a lot of tickets into Epic right now. The app that we're trying to get implemented here, they will have a way to embed it into Epic as well. But one of the things that they noticed, that they've discussed, and we noticed too, was for example, Arshina and Ahmed Abdulazim worked for about a year to get a community-acquired pneumonia order panel in Epic. So basically guides you based on risk factors, which antibiotics to order. And nobody's using it. We've gone around trying to educate the house staff and saying, hey, look, we have this order panel. We've created it for you. It's right there. And one of the reasons probably is because during rounds, they're not putting the orders in immediately then. They're talking about things. And so if they have an app on their phone, they say, oh, what are our guidelines for community-acquired pneumonia? They can look it up immediately. We're hoping that there'll be a better uptake of it. And at least that's what the app company has touted and demonstrated. And they're actually in several institutions. I know Hopkins has like their own in-house app, but this is something that's amongst, I think, at least 100 institutions around the country.
Great. Thanks. Dr. Bhowmick, so you alluded to, kind of the negative aspects of over ordering. I mean, one thing I always say is, if you're not going to do something with the test, don't order it. If you're not going to, know what you're going to do with what you find when you pick your nose before you put your finger up there. And, you talked about, unnecessary antibiotic prescribing. We have patients who, imaging after whiplash in a car accident, and we see all the time, I end up doing thyroid biopsies on these, and they come up to being atypical, but not cancer. And then they get molecular testing, and then they go to surgery, and it was all benign. It wasn't ever going to be anything to begin with. In thinking about high value care, we know that our trainees order more than non-training hospitalists do, for example. One positive aspect is there's education involved. And, so how do we balance that by a learner ordering, an overextensive fever workup, that they are learning a little bit more about fever and the fever evaluation by over ordering? How do we balance that with thinking about the cost of care? And this isn't talking about, which TB test or whether to order LCMS or immunoassay, but how do we think about, preserving the educational value in over ordering that comes with academic education?
Well, I think as long as there is that feedback and understanding that some of these results are now uninterpretable, or, what do we make of it? Because that's something that is still of educational value, that, hey, you ordered a Procal on this patient and they're in renal failure on dialysis and it's high. There shouldn't be an automatic, oh, this means they have a bacterial infection. So I think it's important that they see that aspect of it too, so that they know they shouldn't be ordering the test in certain clinical scenarios, but that knowledge has to be there. And it's hard to have that pre-test probability and test characteristic knowledge for all the tests that are out there. But it's a good question, and we need to have our learners learning what tests to order and what not to order, but they have to have that also feedback to see, oh yeah, we did do it. I remember we did on that patient, it was high and they're in renal failure, we couldn't do anything about it. And I don't know if they always get that feedback.
Wonderful. Anybody, Dr. Jagpal mentioned, balancing factors. How much do we miss by ordering less? How much do we, overcharge by ordering more? It is tough.
I mean, that's that fear of missing the diagnosis. So the studies that I presented today, most of them had also looked at that other aspect of, was there any harm done by us not reporting the results of urine cultures, by us implementing this blood culture algorithm? And they didn't report anything like that. So that's definitely positive, and it might go to show how much over ordering we do. And I'm not saying don't order it. If there's a clinical indication, right, especially when we're talking about the blood cultures, when we were doing this pilot in the MICU, we're saying go ahead and do it. We're not saying not to do it, but we're just telling you to think about what you're doing. Because there's so much rush, I feel like, within medicine, and there's so many possibilities that it's just easy to have an order set and just click away, instead of thinking through, do we really need this test after all? And especially with cultures, we do see so much positive cultures that represent contamination. And there's an example that I give when I talk to the house staff of a while back, pre-COVID. So at least 5 or 6 years ago, there's a patient that came in. They had a positive altered mental status. They did a urine. They must have a UTI. We go evaluate the patient, and they have nuchal rigidity. The patient had meningitis, and it was like completely missed because everyone was so focused on the urine. So it's just important to realize that there are other things to consider, and not always, at least I feel like the urine is the one that gets jumped to a lot. There are a lot of infections that are caused by a urinary source, but it shouldn't be the default.
Tanaya, excellent talk, and excellent discussion afterwards. I'll just wrap up with a question, more of a technological. Are there any rapid diagnostic tests that are currently available or that are in development that you're particularly excited about, or that you think could be further game changers beyond what we're using already? And if they're not, then that's fine too.
I mean, the one that's often touted about, I don't think we have enough information. I don't want to say it out loud. No, I mean, I think it's really the other aspect that we really need to focus. I mean, there are some really cool technology, but it's just that reporting out and making sure that the test is ordered when it's warranted or not ordered in certain scenarios.
And I mean, just to add on that, since you're going to be very politically savvy and not call out the specific name of a test, I think it's not only reporting out and making sure that the right things are being ordered, but I think with coming back to rapid diagnostics, it's also that the results are being utilized and that they're being interpreted appropriately. I mean, you can buy a fancy new car. If you don't know how to drive it, you have a Mercedes, but no one's ever going to see it. I feel like a lot of times people buy shiny new toys that are going to, give you rapid results, but there's no infrastructure, right? There's no feedback to providers. There's no interpretation of the results, or there's misinterpretation. So, I mean, one really important thing that I think our stewardship committee has done is provide sort of that infrastructure and that feedback. But I know it's a challenge, and you guys must be overwhelmed at times.
And I have to give credit to our ID fellows, because now they're the ones who are doing a lot of the culture audit feedback for the rapid stuff. And Arshina is reviewing all cultures, because not all of them get put on the instruments. Since I have the audience too, the T2 Canada is likely going out of business, the company. So we're probably not going to have that test if it already has not fallen off. So it's something that we were kind of sad about, because we feel like that was actually a very helpful diagnostic test to prove there wasn't a disseminated Candida infection and kind of stop antifungals, but also in theory detect cases faster to improve patient care. On that happy note.
Well, everyone, it's 9 o'clock. Tanaya, thank you for a wonderful talk, and thank our audience for participation. Excellent questions and discussion. Everyone, have a great day, and happy Administrative Professionals Day.
Thank you, Tanaya.
Yeah.